this week, it is my great pleasure to introduce Harry Lampiris. Harry Lampiris is a professor of medicine and the chief of the infectious diseases division out at the VA. He has taught many of the ID fellows so much about ID and HIV. I think Harry has probably forgotten more than many of us know about HIV and ID. So it's always a real pleasure to have him come and share his expertise about the HIV world.
Thanks a lot, Annie, for commenting that you think I know a lot, but you really don't need to know anything anymore because you can just look it up.
You need to know if you don't know.
True, that's true. So I think that basically the theme of this talk is how to sequence antiretroviral therapy. So there's like three big cases that I'm going to present, which is how to pick your first regimen, how to switch people when they're suppressed because of toxicity, and then the last thing is how to treat people that are having virologic failure, which we're seeing less of, fortunately. So the first case, you've seen many of you have seen patients like this. It's a 27-year-old gay male who's homeless, and he was recently diagnosed, and he may be at high risk of transmitting HIV. His CD4 count is 320. His viral load is 1.1 million. His EGFR is 90. And so he lives in his car. He stays with his HIV-positive partner in an SRO when they can sneak him in. He uses methamphetamines and is using daily, is trying to quit, and has a history of visual hallucinations while on meth. So the thing about this case is that the ARS choices are getting a lot more, so which is awesome for our patients. But I think every time you start someone on ARVs now, you kind of have to think through what your choices are. And so I'll just say one thing that I'll just start off with the NNRTI-based regimens. So one is efavirenz, FTC, tenofovir, then rilpivirine, FTC, tenofovir, and then I'll skip raltegravir and point out that there's two different ritonavir-boosted PI-based regimens, ritonavir, atazanavir, or darunavir plus FTC, tenofovir. And then you have three integrase-based regimens, raltegravir with Truvada, and then the quad pill, and then dolutegravir, abacavir 3TC, which you currently cannot order as a single pill yet. And then the other option is to wait for your HIV genotype results, or till later in the morning when you're more awake. Excellent. Everyone's going to wait for a genotype. So Monica gave grand rounds at the VA yesterday, and she taught me the art of disagreeing with the audience. So she was like, that's a really great idea, but that's not what I would do. Or it was something like that. So anyway, I guess that there's a movement that's led by Hiroyu Hitano here at the General to start people on antiretrovirals as soon as possible. This person lives in a car, he's using meth, and he's at high risk of HIV transmission. So I think that even in my practice at the VA, that's changed a lot in the last year. We really try to engage these patients instantaneously, thinking that maybe of all new HIV transmission, half of it may be associated with acute HIV when people are hyperinfectious. So although it's not clear that this patient has acute HIV, he has a very high viral load. So does anyone else want to comment on what they would do specifically?
I think it's hard to argue that from a resistance perspective that you'd get in trouble with the PI-based regimen. So I think you have to gauge whether he wants to and can take medicines, but you're not going to run into resistance problems with 4 or 5 if you've sent a genotype and that's cooking. Right. So I think that if you want to start and he wants to start, I would go ahead and start. I wouldn't probably use any of the other options, maybe number 7, but we're still getting data on, well, what happens if there's an M184V there, but you're not going to run into problems with 4 and 5 in terms of virologic suppression, if he takes it.
So just to review some of the reasons not to choose certain things. So everyone knows about the neuropsychiatric side effects. You may know that there was an ACTG analysis last year of patients starting a efavirenz-based regimen versus placebo in a bunch of ACTG studies, and they showed a higher risk of suicide in the group of patients receiving efavirenz. So that was everyone, it kind of speaks against our, I think our previous thought that that was mostly something that was worse in the initial phase of therapy, that neuropsychiatric side effects tended to go away after the first 2 months or the first month, but that in fact, I think that there's some statistically significant differences. And I think a lot of times we were all in denial about those differences because of the fact that we didn't have a lot of treatment options. So the fact is that that is a reason maybe to think about switching people off of efavirenz-based regimens or not using them to start with if your patient might be psychiatrically problematic. And then rilpivirine-based regimens, just to remind people that there's some evidence with Complera that there is decreased efficacy in patients with high baseline viral loads and that they can't be on PPIs. And then, of course, the whole thing about if they're non-adherent, then they have the chance of also becoming resistant to possibly 2 classes. And then atazanavir, ritonavir, or darunavir plus Truvada. And just to say probably that the darunavir, it's probably going to be slightly more active in primary drug resistance. There's probably less darunavir mutations out there than atazanavir mutations. I'm not sure that you can say that one would be more likely to fail than the other. So then you make the decision based upon explaining to the patient the differences, and I would probably favor darunavir if you don't have a genotype. And then I think that the last 2, 6 and 7, so we're excited about having the quad pill as an option, and but I think that we have much less experience knowing if patients are non-adherent, what the impact of the non-adherence is going to be. At least in the Gilead 103 study where they compared ritonavir atazanavir with the quad pill, there seemed like there was less development of resistance in the ritonavir atazanavir arm as compared to the quad arm. So one could argue if you don't know how adherent your patient's going to be, maybe it's better to avoid that until you know if the patient's likely to be at high risk for non-adherence. And then, so I think that I think the jury's out on number 7, but we're very excited because of the fact that there's all this indirect evidence that dolutegravir has a very high genetic barrier to resistance. So, and that there's not a lot of resistance out there. So even though it wouldn't be my first choice, one could make the argument that that's another drug like a ritonavir boosted PI that has a very high genetic barrier, and that if patients' adherence isn't perfect, because it's so potent and the genetic barrier is so high, that that might be a good choice for a significant person, although I still think it's too early. And just to remind you, in all the studies that have been done to date, to my knowledge, when patients have been started on dolutegravir in the context of being treatment naive, they have never failed with evidence of dolutegravir resistance. So the only cases that I know of where people have failed with dolutegravir resistance are in which the patients were treatment experienced. So that again suggests that there's a higher genetic barrier, because obviously it definitely occurs with valtegravir. So I think everyone knows this information, but that the CDC does national surveys on primary drug resistance at 10 US sites. And so the last time they presented this data was at CROI with 18,000 patients. And that similarly at CROI last year, the HOPS cohort presented data on patients receiving genotyping prior to starting antiretroviral therapy over a 10-year period. And so you can see that the results are kind of similar in that on the HOPS cohort, there was about a 16% prevalence of any drug resistance, and it was similar in the CDC cohort. And so just to, again, remind people that if anyone were to ask you this, when you check a genotype on someone before starting therapy, the class to which they're most likely to have resistance that would affect your initial choice of therapy is the NNRTI class, where it's 7 to 10% baseline prevalence of resistance. And that would probably continue to be the agent that would most likely affect your choice, right, the NNRTIs. Because if you had high-level resistance to what the NNRTIs, then you would avoid that class. So the CDC apparently doesn't have funding to do this testing on integrase. And I'm not sure that this study is going to continue, but that's, of course, the big question now that there's a higher prevalence of integrase utilization in the community. The case reports of primary integrase resistance have been rare up until now, but at least I want to show you that it's out there. And so this is some data from Joe Aron and his colleagues at UNC, where they collaborated with LabCorp, and this was just published in CID. And they looked at about 3,000 patients who had an integrase genotype submitted. So this was in their clinical database. So they were being submitted most likely because they were failing raltegravir because during that period of time, that was mostly the drug that was out there that people were failing to. So this does not tell you the prevalence of primary drug resistance, but it tells you when it's looked for that you can find it in the right setting. And so it's also important because a lot of times when you get an integrase genotype early in someone that's failing raltegravir, a lot of times it's a wild type. So that you can, if you can basically get the patient on the right track and improve their adherence, then you can still get them to suppress. And again, now the integrase genotype is really important because it will tell you if there's dolutegravir resistance, since that's the new drug that's out there. So this is what their findings were. Of the patients in which specimens were submitted, about 15% had evidence of primary drug-resistant mutations to either raltegravir or elvitegravir. And I'll get into this later, but they both, it was about 80% of them had one of these two pathways. So it was either the Q148 pathway or the N155 pathway. And then to remind people, this one does not lead to dolutegravir cross-resistance, whereas the Q148 pathway leads to dolutegravir cross-resistance in association with multiple other mutations. So then, of the patients that had genotypic resistance to integrase, 12% would be predicted to have high-level dolutegravir resistance. So that's 12% of 15%, so that's a pretty small number. And that when they did an analysis, they found that integrase resistance was associated with older age and concomitant RT and PI resistance. So at least in patients that are failing, it makes sense, right? Because basically if they're failing an integrase inhibitor and they have resistance to other classes, that's probably why they're failing, because their whole regimen is a little bit weaker. And I personally have extrapolated this in my practice to think about if my patients come in that are newly infected and that they have evidence of resistance to protease and reverse transcriptase, that I get an integrase genotype on them at baseline, even though still the incidence of integrase primary resistance is rare. And that in their database, 42 patients, or 2.3%, had 4-class resistance. So when you sequence drugs, this is a nice, easy way to think about it. Like there are first-generation drugs that have either a lower genetic barrier to resistance, or if they develop mutations, it's easy for them to develop high-level resistance. So with the NNRTIs, nevirapine and efavirenz, now we have these drugs with higher genetic barrier. Rilpivirine, mostly for treatment-naive patients, and etravirine, mostly for treatment-experienced patients. And then darunavir and tapranavir are more active against patients with multiple PI resistance mutations. And then dolutegravir is active, also more active. And so one of the interesting things is that the presence of these mutations, when you pick darunavir, also affects how you dose the darunavir. So that if there are darunavir mutations, we tend to dose it BID to get higher levels. And that's a recurrent theme of this talk, because if patients have evidence of integrase resistance mutations, we also dose with a higher dose of dolutegravir. So we're overcoming some baseline resistance by using a higher dose to treat. So this is just a little thing just to remind you when you're starting new drugs, to remind you that when you're starting someone on Complera, that it's given once daily with food, and it's a normal meal, not a high-protein milkshake, and that there's a high risk of virologic failure if the baseline viral load is greater than 100,000. You have to be careful with certain drug interactions with rilpivirine, with CYP3A4 inducers, and then the use of PPIs is contraindicated. And that when people fail with virologic resistance, they're probably going to develop the M184I mutation, which is a precursor to M184V, and the E138K mutation. And that generally the reason that's concerning is because then that confers cross-resistance to etravirine. So then it kind of knocks out the class. So that in my own practice, this is my personal practice, I prefer to use this drug in a patient that has already proven durable suppression and adherence. And then they're having some side effects or they want an easier regimen, so I switch them to it because I know that it'll be well tolerated and that there's less rash and hyperlipidemia. There's a lot of very appealing things about it, especially if someone has already maintained suppression for a period of time. So then when you're considering starting someone on the quad pill, if you choose to do so for whatever reason, that it should be taken with food. You want to avoid concurrent antacids. So this is different than the PPI effect with the rilpivirine in that it basically binds divalent cations. So it's similar to doxycycline or quinolone antibiotics, where the calcium or the divalent cations bind the elvitegravir and prevent it from being absorbed. And then, so that means that PPIs and H2 blockers are okay, and that you want to limit it to patients with an EGFR of greater than 70. Again, because of the fact that there is this effect of cobicistat, which leads to a slight elevation in the creatinine. And so at this point, it's only been studied, or at least there's only data to use this in patients with a higher GFR. And as you know, then, for example, with other drugs, a lot of times the cutoff for reducing the dose is 50. And then consider integrase genotyping if there's evidence of resistance to multiple classes prior to treatment initiation. And this is my own recommendation that's not evidence-based. I actually wanted to just say one more comment here, is that most patients that have baseline resistance to raltegravir will have cross-resistance to elvitegravir. So that's important. So that, in other words, elvitegravir is not typically going to be a good drug to sequence after raltegravir failure if the patient has raltegravir mutations. So we're going to move on to this case. So this case has baseline primary drug resistance to 2 classes. So it's Y181C and H221Y. So one thing that you should be thinking about is, can you use any NNRTI in your next regimen? And then the patient has 4 PI mutations. So then, just to let you guys know, this is one of the etravirine mutations. And for some reason, they're weighted. Some of the mutations have more of an effect on etravirine. And this isn't the worst one. Y181I happens to be the worst one, which is relatively rare. And there are 4 PI mutations here. So just to let you know, there's no darunavir mutations, but there actually are 4 atazanavir mutations. So then the next question to think about is, what testing would you perform in addition before starting him on medications? So the choices are HIV phenotype or virtual phenotype, HIV tropism assay, HIV integrase resistance genotype, or all of the above. Okay, so I'm glad Monica, where's Monica? So Monica, this audience is very bright, right? It's a very smart audience, yeah. So I was very, very happy with your results. So basically that's just, I don't know if anyone agrees or disagrees with my approach to this, but I think at some point, maybe integrase resistance testing will be routinely recommended in naive patients, but that's kind of my internal practice. No, I do it if they have like baseline resistance to 2 classes. So that proves to me that maybe that they might be at risk of acquiring also integrase resistance. Pras?
Harry, let's say you started him on ART like what you said you were when you came in. 3 weeks later, when you get the genotype back, he has his atazanavir mutations. So let's say you come on darunavir, for example, to start. What's the likelihood that you'll be able to do it and integrate at that point?
Can you repeat the question here?
Sure. So the question was, could you do the integrase mutation? So the question is, if you started them on meds, can you do the integrase resistance testing? And so the answer is no. So the only way you could have done the integrase resistance testing is if you deferred treatment until your first genotype came back. So you're right.
But maybe then, Pras, it's a moot point, because if you started him on darunavir and he's suppressed, then you're done.
No, but I like this thinking that you might consider doing integrated resistance testing in the setting of kind of PI and NRTI resistance. But I guess thinking about how you would do that actually logistically, oftentimes we start patients while we start patients on a fairly suppressive therapy right up front, so we might not be able to have that opportunity to gain.
So Pras, you still also, like within 2 weeks, you might still have a viral load of greater than 1,000, right? So if it was 1 million, then you still might be able to do the integrase genotype if you got the results back in time, right? So if you were lucky. Signy?
You may also be able to ask them to go back and do the baseline sample that you submitted.
Excellent.
So if you submitted the baseline sample, get them to retest that. Or maybe that's a lesson where you keep that on hand so you could resubmit the sample before you put them on darunavir.
I think in reality, Signy, it is a great idea, but in reality, our labs they don't hold on to them. We can talk to Monogram, but usually they say, that's not what you ordered. So you got what you ordered, and have a good day. But I like the idea that they would be nice.
And you can't run that test if they don't have insurance.
Wow.
Also, there's that, yes.
I'm in my own little world.
Harry, as been said before.
Okay. So I just wanted to review this data, which I think is important, that if you have patients who have had a genotype, for example, in the past, and you're trying to figure out if etravirine would still be an option for them, that especially if you don't have a phenotype, that you can use this etravirine mutation score to predict whether etravirine would be active. And so just to remind people, I mentioned that this patient had the Y181C mutation, so then that would give him a score of 2.5. And then you add up all the mutation scores, and that gives you your total. So if the patient had Y181I plus Y181C, then they would have a mutation score of 5.5. And so what they did was they looked at the database from the DUET studies, and they went back, and then they were able to look at the virologic response to patients based upon this weighted mutation score. And again, to remind people, you see Y181C has an effect there, so that that's also an important mutation. And then this is to remind you of how the mutation score affects the virologic response, so that the patients with the highest response had a mutation score of 0 to 2, and if it was 2.5 to 3.5, it was intermediate, and if it was greater than or equal to 4, it was 38% had a virologic response, and the definition, I think, was less than 50 copies at 24 weeks. So that just shows you how that's helpful and it's predictive of how active the etravirine is going to be. So your patient starts on tenofovir, FTC, darunavir, ritonavir. He does well for a year and wants to switch to a simpler regimen. So the question is it safe to switch to raltegravir? Is it safe to switch to rilpivirine? And I'll make the comment here in general that when someone is switching, I'm generally more comfortable if I've found that the patient has had excellent adherence and his viral load is consistently suppressed. So that in my mind, if the patient demonstrates good adherence and the ability to suppress on a ritonavir, darunavir-based regimen, then it's kind of like graduating to a simpler regimen. But again, that's my personal approach. So why do I say that it's important that they maintain suppression? So I'll get to that. So this was a study that's been published now 4 years ago, where patients that were suppressed with a viral load of less than 50 copies for greater than 6 months that were on a ritonavir boosted PI were randomized to continue the PI versus switch to raltegravir. And then the primary endpoint was the virologic suppression at 48 weeks. And so there were about the same number of virologic failures in both arms, 4 in the raltegravir arm and 6 in the PI arm. And the time to treatment failure was not different between the patients that stayed on the ritonavir boosted PI versus switched. So this is to remind you that there were actually 2 studies. And I just showed you the study that showed that there was no difference. But then there was another study called the switchmark study, where patients that were on a lopinavir-based regimen were then randomized to 2 nukes plus raltegravir versus continuing their Kaletra. And that after 24 weeks, the Kaletra arm did better. And then in this study, one thing that was different is the duration of prior suppression on lopinavir, ritonavir was only 6 months. And most failures were in patients on multiple prior regimens. And that in the other study that I mentioned, the duration of prior suppression on ritonavir boosted PIs was 6 years. And they were also, I think, only allowed to have been on 2 prior regimens. So again, the fewer number of regimens you've been on and the duration of suppression means it's more likely to be successful when you switch. And I think also there's a better chance that if it was even dolutegravir, that I might be even a lower chance. But anyway, that's the rationale for waiting if your patients are suppressed before switching them off a ritonavir boosted PI. But I think it's important because everyone wants to do what the patient wants to do because everyone knows that the patient's going to be more adherent to a regimen that they've bought into. But there are just some times when it's relatively less safe to switch people off a ritonavir boosted PI. And so this is the data that we have to date on switching patients to Complera in virologically suppressed patients. So this one is what you might have heard of more commonly is the SPIRIT study, where patients on a PI ritonavir plus 2 NRTIs for greater than 6 months with a viral load of less than 50 on their first or second regimen. with no prior NNRTI used were randomized 2-to-1 to receive Complera versus continuing their PI. And then there was a 24-week analysis, and then all the patients that were on the ritonavir boosted PI in an open label way were switched over to the Complera single pill. And then there was another study that was an open label study where about 50 patients that were on Atripla for greater than 3 months, again, with a viral load of less than 50 on their first regimen. And then they wanted to switch off of their Atripla because of tolerability. So that was the reason they wanted to switch. And then they were switched. And then the primary endpoint was the percentage that was suppressed at 12 weeks. And I'm just going to show you the data together here. So this shows you the study with the SPIRIT study with the 24-week data and the 48-week data, and then the 111 study, which was the Atripla switch study. And so you can see that almost 90% maintained virologic suppression at either 24 or 48 weeks. There was a 5 or less % chance of virologic non-suppression, and some patients had no data. So this is the accumulated data for a Complera switch, either from Atripla or from a ritonavir boosted protease inhibitor. And then this is just to show you that this has also been done with switching patients off of raltegravir to quad pill. So even though this isn't as relevant, I think it's good to know that a lot of patients might want to switch off of off of a raltegravir BID regimen to the quad pill because of adherence, and so because they want to be on a single pill regimen. And so at least this was a multi-center study, which is an open label. People's first regimen was FTC, tenofovir, and raltegravir BID. And then they were, again, suppressed less than 50 copies for greater than 6 months. No resistance, GFR of greater than 70. And then they were switched open label to the quad pill. And so the primary endpoint was less than 50 at week 12. And the secondary endpoints were safety and tolerability. And so at least in the patients that received the, that were switched to the quad pill, that there was 48 out of 48 that maintained virologic suppression after the switch. So at least there's a small database to inform your decision that it's safe to do so. So I'm going to move on to case 2. So case 2 is a 34-year-old woman who was diagnosed with HIV 10 years ago. So she was initially diagnosed with PCP, and her initial lab values were a CD4 of 82 and a viral load of 106,000. So because it was 10 years ago, she was started on Combivir and efavirenz. She did well for a while, and then the regimen failed. And so we don't have the genotype, but she was then switched to Combivir and Kaletra. So now that she's on Combivir and Kaletra, her viral load is 78,000, her CD4 is 125. The tropism test wasn't done. Resistance testing was ordered. And just to review the resistance testing, she had no NNRTI mutations. She had 6 NRTI mutations, and she had 4 TAMs. So 41, 67, and then 210 and 215, and then 184, the 3TC or FTC mutation. And then she had 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 PI mutations, and she happens to have 1 darunavir mutation. So the L33F is a darunavir mutation. So when you're using ARVs in treatment-experienced patients, you have to remember your goals of treatment, which is virologic suppression, which you should be able to achieve in most patients that are adherent, and then finding the best regimen, which minimizes side effects, and use as much information as possible, which means all your old genotype reports and phenotype reports, and treatment history. And then when you're coming up with a new regimen, use 2 or preferably 3 fully active agents when possible, and preferably at least 1 agent from a new class. So this is the patient's geno-pheno report. And so I just wanted to point out a couple things. One is that one thing that comes up is that even though the patient has a lot of NRTI mutations, there still is phenotypic sensitivity to tenofovir. So we call that genotypic-phenotypic discordance. And so that suggests that I think usually we tend to continue tenofovir in those kind of patients in their future regimens because of the fact that there's some residual activity, although there's some data from an ACTG study more recently that suggests that we may not have to do so all the time. And then This patient had no NNRTI mutations, but you can see here the patient actually had NNRTI hypersusceptibility because of the high presence of thymidine analog mutations. And then down on the bottom here, you can see there's a bunch of PI mutations, and that interestingly, sequinavir and tapranavir were the most active. And with the one darunavir mutation, darunavir wasn't on here yet because it was a genopheno that was done before darunavir came out. So the question is then, can you determine whether darunavir ritonavir is a good option for this patient? Can you treat this patient with darunavir ritonavir 800, 100 QD, or should you use it as 600, 100 BID? So this is to remind you that there are 11 major mutations associated with darunavir. This patient had L33F. It's approved for both first-line and treatment-experienced patients. You can use the QD dosing in treatment-experienced patients if there are 0 darunavir resistance mutations based upon the Odin study, and that the power study that patients treated with darunavir and optimized background had a better response, and that it was found to be dependent on 11 mutations at baseline, and that there tends to be a dramatic decrease in activity if there's greater than 3 darunavir mutations. And just so that you know, if there's anywhere between 2 and 4, it's very hard to predict the phenotypic sensitivity. So that would be a situation where you might also want to get a phenotype. So which regimen would you start this patient on? So just to remind you again, she had multiple mutations. She had 1 darunavir mutation. She had some partial activity to tenofovir, and she had no etravirine mutations.
One regimen that I don't see on here, there's obviously a lot that you could do just while people are totaling them up. That's I've really grown to use much more is darunavir with Complera, because it really reduces the pill burden, and you can give darunavir with rilpivirine. So if they have
That's great.
Susceptibility there, it's been a really nice option, so you don't have to do the twice a day with etravirine.
Great. So again, this is an audience that is true to my heart. So that basically, like Annie said, that you might have another option if you chose to use rilpivirine with the darunavir. Although I still think you'd have to use the darunavir BID. So I don't think that that would be huge. I think that wouldn't be hugely beneficial from that point of view. And then another option would be darunavir, etravirine, raltegravir. And then does anyone want to comment upon? Well, I just want to say that what's really nice about this is class sparing, so that you're basically not exposing the person to an integrase inhibitor unnecessarily. And that was the regimen that was chosen for this patient. So you started this patient on this regimen. She does well. And then after 2 years, her CD4 count is 400, her viral load is less than 50. She complains of low-grade diarrhea and bloating and wants to change her darunavir ritonavir to something else. So she's maintained suppression, and she wants to change off of her darunavir ritonavir. So your advice to this patient is tell her you cannot stop darunavir ritonavir safely without starting T20. That's how to make friends and influence people. You switch to Truvada, etravirine, and raltegravir. Or you get a trophile DNA assay, and if the virus is R5, then you switch to Truvada, etravirine, raltegravir, and Maraviroc. I think that the right answer is number 2, and that we have a lot of patients that initially we weren't sure if they were, the genetic barrier of this regimen would be good in patients that were not being able to take a ritonavir-boosted PI. But there was at least one study called the Bravo study, where etravirine and raltegravir were used without a PI, and that there was a good salvage response rate. But I want to point out that you can't do this with dolutegravir, because if you're using etravirine and dolutegravir, then a ritonavir-boosted PI must be present. So etravirine induces the metabolism of dolutegravir, so it's going to lower the dolutegravir levels. So this is a reminder for those of you, again, just so that you know, these are the 3 commercially available tropism assays. So the one that we've used the longest is the Trophile assay for Monogram, the phenotype assay, which you guys know that costs $2,000 for an assay, and that it can detect a mixture of at least as little as 0.3% dual mixture X4 virus, and that in the chance that your patient's viral load is suppressed and you still want to get a tropism, you can do the Monogram DNA assay, which uses a similar technology, but it uses your PBMC DNA to do the phenotype. and that most recently there's a test that's available called the Quest HIV tropism genotype. And so this is a test that performs sequencing of the V3 loop of the ARV gene, and that if the genotype doesn't show evidence of X4 or dual tropic, a second test is done, which is a 454 sequencing looking for minority genotypes associated with dual tropic or X4. So all of those are available. The first two tests take longer. The last test is the cheapest one. And I actually think that, although this is controversial, I think they all perform pretty well. And that if you talk to many HIV thought leaders across the country, a lot of them have actually changed to the Quest assay because of cost reasons. What do you guys do?
I don't know if we can get the Quest one. We can get the monogram profile, again, dependent on insurance and whether we can get a voucher, et cetera. So there's some barriers there, but we can do it, and have not generally done the profile DNA for the reasons you point out. Just it's not been clinically helpful, and we don't know what snapshot in time that reflects. So if you really need to know if Maravrock works, I don't feel like you can fully trust what that looks at, unless it shows you that they're X4. I think if it shows you they're X4, that's helpful, but given a resource-constrained environment and all the options we have, that's rarely been the case.
And it's also very hard to study prospectively clinically.
Exactly.
So now you started the patient on your Bravo regimen, Truvada, etravirine, raltegravir. She does well for a year. Then she relapses on crack, and she's taking about 50% of her doses. The CD4 count is 140. The viral load is 12,000. She's dual tropic, and her genotype and phenotype are similar to prior. And the integrase genotype shows the N155 mutation. So this is to remind everyone of the genotype pathways for integrase resistance. This is raltegravir. So what's important is that most people have either the N155 pathway or the Q148 pathway, and that the N155 pathway does not lead to dolutegravir cross-resistance, nor does the Y143 pathway, which is less common, and that basically the Q148 pathway, in addition with multiple additional mutations, is associated with the development of raltegravir resistance. And so this is just an interesting mutation to be aware of, the R263 mutation, which has been occurred in the setting of dolutegravir failure, but it seems to be a virus that's very unfit, so that it's basically pretty uncommon, and it leads to dramatic reduction in viral fitness, which is maybe why it's harder to actually develop resistance to dolutegravir clinically. And this is just to show you that you can have multiple different pathways at the same time. So this is showing people that were in the initial studies with raltegravir that you can see their first mutation a lot of times was the 155 pathway. But then if you continued the failing regimen with raltegravir, then a lot more of them developed the 148 pathway. So the reason that's important is two reasons. Number one, when your patients are failing raltegravir-based regimens, you want to get a genotype right away to figure out if you can salvage them with dolutegravir. And then also, a lot of times it'll come back wild type so that you can reinsure, like basically you can encourage the patient to be adherent and continue their regimen. But if you feel like they can't be adherent, then you probably should change them off the integrase inhibitor if you can. And this just shows you the elvitegravir and raltegravir pathways. So again, this shows you that 155, 148, and then there's a different pathway, the 147 for elvitegravir. There's the 143 pathway. But remember, if you develop multiple mutations to raltegravir, you're probably going to be cross-resistant to elvitegravir. Whereas if you have a lot of mutations in this pathway, the 148 pathway, that's when you're likely to develop dolutegravir cross-resistance. So I'm just going to try to, in the last few minutes, go through some more recent trials in treatment-experienced patients. So you guys know these older studies. So this is treatment-experienced patients that got either raltegravir, the DUET study where they got etravirine and darunavir, the MOTIVATE study where they got Maravrock, and then the TRIO study, which a lot of people talk about, where they actually got all these three new classes together, where they got raltegravir, etravirine, plus darunavir, ritonavir, and they had a very high response rate. So I think that if you learn the studies, the benefit to learning the studies is that you can figure out what drugs go together and that you can say that it's been validated in clinical trials, so that at least it's a little bit more reassuring than kind of making up the regimen on your own. So try to think about, like, for example, etravirine and darunavir we know go well together. And so the 3 new studies I'm going to review are the SAILING study, which is a treatment-experienced patient where the patients were randomized to dolutegravir versus raltegravir. The ACTG option studies, which ask the question about if you're starting someone on a salvage regimen and you're using at least 2 new good drugs, are the continuation of nucleoside analogs necessary? And then the last study, the Viking study, which is an open-label study of dolutegravir versus raltegravir in patients with integrase resistance. And the Viking 3 study was one in which patients with raltegravir resistance were then given open-label dolutegravir. So the question is, can we omit NRTIs in second-line antiretroviral after PI failure? So the ACTG option study randomly assigned 360 patients who had PI failure with NNRTI experience or resistance to optimized antiretroviral with or without NRTIs. So just the baseline characteristics, the baseline CD4 was about 200. The viral load was about 10,000. Half the patients had R5. And they were highly treatment experienced in that 20% were T20 experienced. And the phenotypic sensitivity score was 3. And then 56% used the trio regimen as their salvage regimen. So the reason that's important is that we know that's a very potent regimen. And so they found that basically there was no difference either in regimen failure or virologic failure at 48 weeks. They don't really have a good explanation for this, but it seems like there was a higher mortality in the NRTI arm. But I think that this is important to know that if you have a significant number of options in the background, a significant number of new drugs, maybe the recycled NRTIs are not necessary. But I would also argue that if you can add fewer drugs in your new regimen, that maybe using the recycled NRTIs is not a bad idea because they have a low pill burden and the patient has already proven that they can take them, especially if they're able to take tenofovir in their salvage regimen. Annie, or anyone, do you guys think that this study has actually changed your practice?
I think it has a little bit. I think it gives you the liberty to let go of the nukes. I think 3TC is harder to let go of depending on the situation, but tenofovir in the long term has a lot of side effects and potential toxicity. So I think it's let me let go of tenofovir in some patients, and they've done well. So I don't think this was a very hard study to conduct and enroll, so it's not going to be done again. So I think these are sort of the best data that we're going to have to help inform the question at this point in time. So I've actually taken tenofovir off for patients based on this, and they've done fine.
So I think that you probably have all heard about this study, but I'm just going to review it. So this is dolutegravir versus raltegravir in treatment-experienced patients, but they don't have a history of integrase exposure. So that this is looking at when you're adding an integrase inhibitor in a failing regimen in patients that have never received an integrase before. And so this was integrase naive and raltegravir versus dolutegravir, week 48 data. And so the patients were integrase naive and they had 2 or more class resistance. And it was a multi-center international study. They got an optimized background regimen of 2 drugs, at least one of which was fully active. And they were randomly assigned to optimized background plus dolutegravir versus raltegravir. And this is just some of the baseline demographic information. And so what's important here, I think, is that about a third of the patients had a phenotypic sensitivity score of less than 2, and that there was 3 class resistance in approximately 50%. And I think that's important because of the fact that now in salvage studies or in treatment experience studies, you want to make sure there aren't too many active drugs in the background, or your study might not show a difference between your 2 arms. So the primary endpoint was virologic suppression at 48 weeks, and the dolutegravir arm was statistically superior, 71% versus 64% at 48 weeks. And they did some other sub-studies, but one of the things that for protocol-defined virologic failure, it was 12% in the raltegravir arm versus 6% in the dolutegravir arm. So at least this establishes the fact that for many patients, that maybe we shouldn't be using raltegravir in treatment experience and using more dolutegravir because of the fact that it seems to be superior. And then, again, you can still use the dolutegravir once a day, 50 milligrams, because there's no integrase mutations. And so the tolerability was similar, and then there was a higher incidence of the development of integrase resistance in the raltegravir arm, 5%, versus in the dolutegravir arm, it was 1%. And again, this is where they saw this weird new mutation that I'm just going to briefly mention. This R263K mutation. In vitro, it leads to this dramatic reduction in replicative capacity. And there are no secondary mutations that seem to be able to compensate for this. So maybe that's the reason why it tends to do so well in treatment-experienced patients. So Viking 3, this is a study that was just published last month in JID. And so this was treatment-experienced patients where they actually had mutations to raltegravir or to an integrase and resistance to at least 2 other classes. So they had 183 patients, and it was an open-label study where they added dolutegravir, and then they did an 8-day monotherapy lead, and then they started their background regimen. And so that they also had to have a sensitivity score of at least 1. So there had to be at least 1 active drug in the background in addition to adding the dolutegravir open label. And again, this is dolutegravir BID. So these patients had a median prior ARV exposure of 13 years. And this shows you that they were highly resistant to NNRTIs and PIs, and that they all had integrase resistance mutations. 23% of the patients were women, and 27% of the patients were African American. And so this shows you now that there was statistical superiority. Sorry, it's an open label study, but 70% had virologic suppression of less than 50 copies at 24 weeks, and 56% had virologic suppression at 48 weeks. And that this was a highly treatment-experienced patient. It's a remarkable degree of virologic suppression in patients that have this degree of baseline resistance. And then this is an analysis of the response at 24 weeks based upon the baseline mutations. So most patients with the mutations did well, unless they had this Q148 pathway and 2 secondary mutations. And then the response rate went way down. So this, again, was predicted by prior studies that if you had these secondary mutations in that pathway, that would reduce the response to dolutegravir. So just to summarize, there are lots of choices in second-generation drugs in dolutegravir and also NNRTIs, both naive and treatment-experienced patients that have improved options for our patients. Early studies suggest that NRTIs may not be necessary in salvage regimens as long as there's an adequate number of new drugs. Your salvage regimen should include at least 2 or preferably 3 active agents, but that adherence counseling and close follow-up is necessary given the relatively few options for patients in the immediate future. And thank you for your attention.